Hello, everyone. Welcome back to Straight from the Hip. This is our third episode. So first off, I want to say Happy New Year to everyone. Happy New Year to you, Benoy, because I'm looking at
Happy
you.
New Year.
So
Happy New Year.
did
Yeah,
you,
it's great too. Yeah, I had a
did you
good
have a
bit
good
of a break.
Christmas?
Yeah, just back at Birmingham. It's just I definitely needed that 2 weeks, and I don't know about you. We just been snowed in, and UK, we are not prepared for snow, and so a lot of disruption. So I think we're just recovering from the shock of going back and all the weather changes. I'm sure you didn't have any of those back in Australia.
Yeah, look, I'm not going to look at you as I say this, but no, it's been 35, 40-degree heat over here.
Yeah.
Having fish on the beach for Christmas Day was very bizarre, but I think we fitted in. I think we fitted in with the Australian
Yeah.
community. I like to
How is
believe we
it?
did.
Yeah. Did you have all the turkey and all the like normal stuff what you have at home, and do you have sort of it's a bit different?
No, that's weird.
Mm.
Australians look at you very weird if you have roast dinners and things like that on Christmas Day. No, it's very much barbecues, it's fish on the beach, it's cold food. It's a very, very different Christmas for me this year. But still
Mm.
fun. Still
Yeah. So
fun.
it's yeah, good, and at least catching up. I believe your friends came down and you had a good time with friends as well from UK.
Yeah, we did. They didn't get sunburnt. We looked after them. But yeah, no, it was good. I think if we
Okay.
didn't have some friends here, it would have been quite a depressive first year. And so it
Yeah.
was nice to have some friends here with us. That was good.
Excellent.
Feel recharged,
Excellent.
feel refreshed, which is what it's
Brilliant.
about.
So we got exciting 2026 with all the stuff we planned.
And we're kicking it off right here.
Yeah. Brilliant.
With our new project. So this third episode, we're looking into FAI mimickers. So we did our subjective assessment, we did our objective testing, etc. Today we're going to be talking about FAI mimickers. So things that can present very, very similarly to FAI. I think, Benoy, you're going to be talking us through most of this. So I know that you want to cover three of probably the most common FAI mimickers, things that you're more likely to see. And then we've got three that are slightly less common, that you could still see, but not as common as the first three. So that will be taking you through six, essentially, in this episode. So, Benoy, what is your first one? What is the first mimicker
Yeah.
of FAI that
Yeah.
you see?
Yeah. So I think before we go in, might be useful to cover a couple of points is why should we, I think it's natural for us to feel, so somebody comes in with activity related joint pain, they get pain on sitting and squatting. Obviously it's more likely to be impingement, but we should be careful not to jump in straight in and label them straight in, because there's two issues I think we have. One is the demographics which have impingement also get so many other conditions like the bone stress and proximal item, which we'll go through. So they are likely to also have other pathology, and pretty much there is no test as far as I know, like all the tests which we talked about in the objective are also positive in other condition. For example, the impingement test is also positive in hip dysplasia and hip OA. So there is no like any particular test which we can say with certainty that it's definitely hip impingement. So I think what we can say, it's more likely to be intra-articular, and then the profile fits in. So those are the two reasons I believe that we should be mindful that not everybody comes in. So if you look, there's I think a review which looked at, if you have 10 patients who comes in with activity related pain below the age of 40, which rules out OA, it's around 60% who are likely to be hip impingement. So you're more likely to see hip impingement, which is great because common things happen commonly, but the 30 to 40% will be things which you might miss. Now, some will argue, does it change management? Because there's usually the classical debate we have, does the labeling change the management? And I think in some cases, like the bone stress, it could be disastrous if you miss those sort of things, unlike the avian and things like that. So I think we need to be mindful that it's not just labeling anybody with hip impingement just because you're active, and then having a checklist. So obviously, me and Callum are sharing you that sort of a checklist, but this is what we've picked up from experience. So it's always being mindful of this pathology. So I think let's start straight from bone stress. So this is something which I have picking up. So I don't want to name any apps or any devices, but I don't know about you. I've just picked up the last week when I gone back, two female runners who have been, there's sort of some good apps which tell you like running 5 days a week, big ramp up, and then classical bone stress, So there's online, obviously there's benefit of online training and other AI sort of stuff, but sometimes it's not overseen by a healthcare professional and we get up with injury. So let's start with the first one, which is the femoral neck bone stress, which generally tends to happen in the same demographics. You're talking about runners, and we know from the literature it's more females. So what are the key things I look out for from the profile? So you're talking about somebody who is having a recent spike, possibly training for their half marathon and also their full marathon. Previous history of bone stress, which is the huge one. So we know one of the strongest risk factor is previous bone stress. And I think I remember this line quite well from a course I did with Rich Wiley, where he says, which injuries with bone stress higher above the knees, so more towards the hip, are mostly driven by low energy availability rather than biomechanics. So I'm not going to put them on the treadmill to look for biomechanical impairment, which might be more relevant later. But this is where I think I've changed in my practice is I routinely check with every runner about their fueling habits. So what are they eating? Have they changed recently being a vegan or vegetarian? Do they do one meal a day? Are they cutting out are they having anything after the training? So the dietary, obviously I'm not a dietitian, but I need to know, are they fueling their training and runs? So that's a big part. And also looking into some basic stuff like your hop test, the fulcrum test. But we have to be mindful. I think it was before Christmas, I had two runners who came to me with this classical hip bone stress, femoral neck. They had all the pain on hop test, a bit of energy issues. And then I obviously stopped them from running and sent for an urgent MRI. But the MRI came back as acute flare-up of FA syndrome. It was a bit of synovitis, and fortunately, it was not a bone stress. So even with all our extensive experience, I find it extremely difficult to differentiate between an acute FA flare-up and a bone stress. They are very, very similar. I don't think there's any test. So I think here, the key point for the bone stress here is the diagnosis is mainly driven by history alone and the profile rather than clinical test. So, on this condition, I would immediately offload them. And unfortunately, the X-ray will not pick it up if it's more in the early stages. So you might want to rush them for an MRI, stop running, if they're limping, give them crutches and try to seek help from a sports doc or orthopedic surgeon. So that is the one not to miss. And you might, the common question is, why should we go for an MRI rather than X-ray? Because this injury is a high risk bone stress injury, and it's more likely to develop into complications and things like avascular necrosis, and it could have a big impact on their long-term career. So it's definitely on your checklist. This is one not to miss, especially if they're coming from an endurance background. So those, obviously, we plan to have a separate podcast, but those are the key points, Callum.
Yeah, well, I think something you and I have spoken about privately before, Benoy, was orthopedics, and I'm leaning much more on the NHS, sort of my times in the NHS. Orthopedics like an X-ray first before we go down the route of an MRI. So the question that I sometimes get is, Callum, should we be going for an X-ray even if you think it's a bone stress injury, or should we divert straight to the MRI if your suspicions are very high? What would be your experiences there?
Yeah. I think in the setting, it's massively. For example, when I work in the NHS setting, APP, it's a standard to have an X-ray. Like you must get that. It's like the fracture clinic, and it does have its benefit because if you do see it on the X-ray, then you can really fast track it. But in the private setting, so I can say from a private setting, if when I work in Central London, Baker Street, if somebody comes in, I'm going to go straight for an MR because that will help me to pick up the red flag. So all depends on the setting because you most of the time when you refer to the NHS, it'll be X-ray first, then the MR. But in a private setting, I would say, if you don't do it yourself, then seek somebody. And one of the things I feel it's really important with dealing with hips is having the network of people to support you. The women's health physio, your sports doc, your dietitian, your personal trainer. This is not a job to be done on your own, in my opinion, because it's such a complicated area. So I would immediately link up with somebody on that. So yeah, to answer your question, it depends on your setting, but I would go for an MRI first, especially if you're a lone worker or in a private setting. Would you agree with that?
Yeah, definitely. I think where I am in a private setting here, or split between, primary care and a private practice here. Privately, we've got that option to just go straight for the MRI. Where you're working alongside GPs, a lot of the time, there is a protocol in place where you need to go for the X-ray first. It's always a bit of a tick box that the public sector has. So in private, you've got a lot more flexibility. So yeah, I'd agree with you there. Sure.
So moving on, I think, yeah.
No, the next one, I know that this is a big one that we could spend a whole hour talking about this one, but
Yeah.
hip dysplasia versus FAI
Yeah.
that commonly coexist.
Yes.
How would you
That's the thing.
separate the two?
Yeah,
This is
and the
the
thing is,
flaws to
yeah.
you here, but I.
Yeah, so I think is, yeah, it's what many are not aware of, which I think you recently did a post, which is very important to highlight is we like to, when we teach courses or when we discuss, we like to put things in boxes, but the reality is they coexist. There was one review I saw which said nearly 40% of people with hip dysplasia also have coexisting CAM morphology. So that's nearly half. So I think what we can say is like it's more likely to be one which is driving that. But when you look at pure hip dysplasia, there are some key points which will help us here. One is generally it tends to be more females. So some studies have shown it's 70 to 80%. So if it's more, a female patient with hip impingement, then the likelihood is a bit more higher. But there are some key 3, 4 points which I'll go in a bit more detail. First thing is childhood, looking at the childhood issues. For example, I want to know if they have any issues when growing up, were they diagnosed with hip dysplasia when they're young? Did they use braces? And the next big one is the family history. So talking about did they have early hip replacement, especially below the age of 60, especially their parents and siblings. And then a big one is presence of hypermobility. So I'll do basic screening. Do they double jointed? Do they have a history of, when they've been told by somebody that they have hypermobility? Because that also raises my suspicion quite highly. And then also the sensation of giving away. So the people with hip dysplasia generally report that sort of giving away where it's sort of popping out. And they might also have coexisting conditions like snapping hip as well, because they usually go together. And then practically when we do, which we'll go in detail in a future episode, we'll be looking into the instability clusters, So there are 3, 4 of those. And then, so the key one is if it's a female patient, childhood history, hypermobility, plus positive instability, think dysplasia. So that is sort of a key short summary of what I look for.
Something that I was asked by one of our team members when I delivered a CPD recently on hip dysplasia was, what is the difference between what a patient tells you symptom wise with FAI versus dysplasia? What would you say are the key differences in how a patient describes if you're thinking FAI versus dysplasia?
Depends. I think the one thing is it depends on the stage they come in. So when they come very irritable, when suppose they are in a flare up, both are very similar. Everything hurts. They can't sit there, sleep. But if you look at from initial stages, there are a couple of points. One is, as we know, the diagnosis or the definition of FA syndrome, it's a motion related disorder. So it's very specific to certain activities. So sitting, squatting, and those sort of stuff. Whereas with hip dysplasia, it's more an instability spectrum. So they usually will have issues with prolonged standing, running, and also, anything impact based. Plus, they also have this overload of your glutes and the hip flexors. So I think there's been studies from Denmark where they've shown that the muscle group which overworks more in hip dysplasia is the lateral hip and the hip flexors. So that's why they get diagnosed as GTPS and hip flexors. So they don't tend to have the classical groin sort of, it's more on the lateral side. So the ags are main factor for me. It's more weight bearing. It's more the standing. And then they also have that ache where they feel it might pop out or give away, and the sort of ache as well. But most of those symptoms, they overlap. So this is where the hypermobility screening is really important. So the objective really helps us here. So screening using a Bayesian score or whichever score you use, plus doing the cluster, plus the profile massively influences that. So those are the key points to look out for.
Yeah, perfect. One other little question I'll throw at you, Benoy, and this is more
Of
stuff
course, yeah.
that's been thrown in my direction recently. You mentioned hypermobility. I would probably say anecdotally, in my experience, a lot of patients haven't been formally diagnosed with
Mm,
hypermobility.
mm,
How do you go about wording your questioning to that patient, especially if it's a young girl, we'll call it a 17-year-old girl,
mm,
mum or dad
mm,
is present. How would you
mm.
go about asking them if they've been more flexible, if they feel they're double jointed, but we haven't
Yeah.
got an official diagnosis of hypermobility? How would you
Yeah,
communicate that?
yeah. So there's an official five question tool. It's by thing Hakim tool, which is published. So I don't remember all the five. We can share it later. But 2, 3 questions which come to me is one is asking them, have you been told that you're double jointed by someone? And do you do party tricks like splits? And does you have a history of clicking of the, like where you have patellar subluxation or shoulder subluxation, not full dislocation, but you have a history of joint issues with your knees and the shoulders. because those are linked up with those sort of conditions. So you'll start with some like basic, just testing the waters, and then usually say, yes, I'm always flexible, I do party tricks, I can do splits, I can touch the floor. So that usually tells me. And also one of the things which guides me is, usually we find people who are generally flexible are involved in more performance sports. So if somebody comes from background of ballet, yoga, those sort of performance art, circus sort of things, then obviously that if you're somebody like me, or possibly like you, we won't be doing those stuff, isn't it? I don't know about how flexible you are. So if a young female says she does ballet a lot, or she is sort of doing a lot of high level performance art, then the suspicion is very high. So I'll also inquire about what sort of training they're doing, and what areas are they sort of spending the time, because that is a clue about the flexibility as well.
Yeah. I don't know if Benoy, you might, is it the Hakim and Graham?
Yeah.
Is it the
Yes,
five
that's
the
the one.
5 point scale?
Focus.
Yeah.
Yeah. 5 point question, five
Yeah.
questionnaire. Do you want to
Yeah. I
maybe
think we
add some more?
Yeah, no, I think that's something that we might be able to attach to this podcast, because it's a recent
Yeah.
paper, isn't it? They had
Yeah.
kind of what Benoit's been alluded to there, 5 points on that questionnaire. And if they essentially score yes to 2 out of those 5 points, then you're thinking they could be hypermobile. But again, you couple it with your Baton score, you lead it, you refer on. But that is quite a nice new score that's just been published that we might be able to attach to this podcast for
Of
people to read
course.
further about.
Yes.
Um, no, perfect. Is there our third and final of our top 3
Yeah.
mimickers of FAI?
Yeah. So other one is an obvious one, but it might not be obvious with the young. So when you talk about hip, the obvious one is hip osteoarthritis. So most therapists are aware of people in their 50s and 60s with hip OA. So classical symptoms where they have the stiffness, and they also have poor internal rotation. What we're talking about here is the active early hip OA. So generally in the late 30s and early 40s. So I'll just give you an example. I had this female 42, 43 who's been round the blocks with chronic buttock pain, and then been diagnosed with proximal hamstring, ischio-femoral impingement, and not responding. So when I first saw her, one of the first questions I asked is, do you have difficulty putting shoes and socks? And it was a clear yes. And she said it's more a stiffness. So sometimes the obvious ones are missed, because we don't really think that somebody who's really active doing half marathons can get hip osteoarthritis. So then we should be looking into the classical symptoms like stiffness, especially with prolonged sitting, struggling with the loss of range. And also, we know people from a very athletic background, people who have done a lot of rotational sports. Unfortunately, there seems to be high risk of getting early osteoarthritis. People like who play a lot of football, rugby, those sort of background. So don't assume it's just hip impingement acting up. It could be early. So this is where I think when we discuss in the next episode about imaging is useful, because the OA is generally seen on X-ray. And this will change the management conversation, because one of the key elements is having osteoarthritis is a strong contraindication for hip arthroscopy. So the surgeons I work with will not really be offering hip arthroscopy. So that is going to change the management. So always have that sort of, and you'd assume hip OA is picked up. And I was quite surprised, like how often, especially in the active population, it's missed for a long time, and people blame the soft tissues.
Yeah, I think there was once a time where we thought of hip osteoarthritis as being anyone over the age of 50. And then we said, oh no, actually, it's probably everyone over the age of 45. Then it went down to 40. I suppose we're talking about people even in their mid 30s can have hip osteoarthritis. And I suppose you're saying is that if we dig deep in our subjective and we find this person has got a very heavy sporting background, suffered hip injuries before, maybe they've had a minor minimally invasive hip surgery in the past, or if they had an adolescent hip condition as a child, then hip osteoarthritis can present much, much earlier, even as early as 35 years old. I mean, would
Yeah,
you agree with
definitely.
that?
Definitely. And doesn't mean that they have to. One of the things we have to be careful is there's a perception in the public that, "Oh, I've got hip osteoarthritis means I'm going to have a replacement next year." It's most of the cases can be successfully managed with the rehab, with load modification, and even getting them back running. So it's something which we have to sort of give that positive message. It doesn't mean like it invariably will decline, but we can manage it really well with a combination of physiotherapy. In some people, it will be losing the weight and things like that. So it's really important to keep that diagnosis on the table, especially the one, especially we know men who have played a lot of rotational sport is slightly higher in men who come from rotational background. They are more likely to pick up early osteoarthritis than.
Yeah. I think the education around is what's so important, isn't it? The education around any condition. But I
Yeah,
suppose, especially osteoarthritis, where the general public have this perception of wear and tear and degrading away. As you said, having arthritis can often be a normal finding on imaging. It doesn't necessarily mean surgery is inevitable. So I think that education is absolutely paramount with that cohort. You had three less common mimickers, Benoy.
yeah,
One of them that I think you and I have spoken off camera was proximal ITB pain or proximal
yeah,
ITB syndrome that we're seeing a lot more in the endurance cohort.
yeah,
How does that present differently to
yeah.
FAI?
Yeah, so I think a couple of points. They present very, very similar to hip impingement and hip femoral neck bone stress. So it's the same sort of cohort here: active, endurance patients, generally running. I've also seen it cycling as well. Usually a lot of trail runners. And if you look at the literature, it's just like femoral bone stress slightly higher in females. So they present in two, three different ways. One is they complain of this deep, annoying ache, which is where it sometimes has misled me to think it's intra-articular. It's not always pinpoint, so they don't really put like a finger on. Some patients do, but most people say it's like a deep, annoying ache, which feels like many people don't believe when they say it's more like a superficial origin of the proximal IT. They feel like it's more deeper, and the pain is generally around the ASIS TFL origin. It seems to be higher than the typical C sign. So when we teach courses, I call it the high C sign. So the normal C sign is pretty much a bit lower around the groin. This is a little bit more higher where they hold it around your ASIS. And then the profile, when you look, it's female runners and linked with biomechanic impairments like crossover gait. And when you test them on and handle dynamometer, they have significant hip abductor weakness. And then this is a fairly simple diagnosis. If you palpate over those ASIS TFL origin, you can reproduce the pain. It's like a pinpoint area. And then if you have access to ultrasound, it's one of the most superficial areas to scan in. But in theory, you don't really need that. So it's a location of pain, the profile, and also not the typical groin lower down. So that's is your key points to look out for.
The crossover gate that you
Mm.
mentioned, for anyone that isn't familiar with what that is, could you explain what that would look like? And is that
Yeah.
something that you look at with walking, or depending on symptoms, do you get them on the treadmill and look for it there?
Yeah. So I think that's a great point to look out is, so generally when somebody is irritable, I don't really look at running analysis. So this is usually seen as part of gait analysis. So we call it the medial, sort of collapse. So we know from the literature, female runners are generally having more hip adduction and internal rotation. So there are two things which we generally see. So conditions like ITB syndrome, GTPS, and proximal ITB share the same biomechanical impairments. When you see them running, one obvious one is the dynamic knee valgus, where you have the contralateral hip drop. So that is much more common. And the other one which we see is, so when they're running, they're sort of crisscrossing. If you imagine you got a line when you're running, they're crossing over that line, and quite easily seen on the treadmill. And I use just my iPad to record it from the back, and then you can slow it down, and it's quite obvious to see that sort of crossover gait. And that can be retrained by a combination of strength training and specific cues to get that excessive overload on the lateral structure. But this biomechanical finding is not only for a proximal ITB, but also linked with distal ITB and also GTPS. So it's a common thing, especially in female runners.
Perfect. The next one that is very difficult clinically
Yes.
is ischio-femoral impingement.
Yeah.
Some people may not have come across ischio-femoral impingement before, but it
Mhm.
is probably one of the more, if we're talking about buttock pain, it's probably up there with one of the more common ones. Do you feel that that can mimic FAI as well? Can that present very similar
Yeah.
clinically?
Yeah. So I had this patient, I think it was in November I saw her. So she came with classical hip impingement presentation, C sign, groin pain, buttock pain. So my guess at that time was the pain she was getting in a gluteal region was referred from the FA syndrome. So she had pretty much
Mhm.
all the symptoms there. One thing she also reported was she had difficulty because she also does yoga. So she had difficulty in doing like deep lunges, like the warrior pose, where you're going into excessive hip extension as well. And she was struggling with that end range extension. So she was not improving with my typical hip impingement rehab. So my query of sending her for the MRI was mainly to rule out bone stress. I didn't really think it was anything else. So we sent for an MRI. Unfortunately, it was not bone stress, and it came back with all the signs of ischio-femoral impingement. So generally, with this pathology, there is swelling and pathology involving a key muscles, which is part of the external rotators called the quadratus femoris, and they tend to also have a smaller ischio-femoral space. So it's more a muscle pathology deep in, and that can cause your symptoms of deep buttock pain radiating into the groin. And then once I had the MRI, then I did the testing, which was there's a specific test where you put them in side lying, take them into end range extension called the ischio-femoral impingement test, and then her pain was worse. But I have to be totally honest, it is something which I didn't really pick up because she was so typical FA syndrome. So this is a condition I wouldn't really be too hard on any clinician not to pick up, because this is something which I have always picked up after the imaging comes in, because my concern always been bone stress and FA syndrome. And when they come back, then I modify. So how does it change here is made a big difference in the rehab is I totally stopped that end range extension loading for a good 6 to 8 weeks. And that really calmed it down. So she was doing a lot of bridging, a lot of walking lunges, a lot of the warrior pose in yoga. So they were really irritating that structure. So it totally different from what you would say for a hip impingement. So it makes a big difference in the management. But sometimes the only way you can pick it up is on imaging. So it's being quite. I'm being being realistic here that it's one of those hard conditions to pick up purely by clinical, and that's where the limitation, which we can talk about imaging in the future episode, where it's really useful, where we only generally pick it up there.
Yeah, and I think it comes back to your earlier point, Benoy, was that diagnostic labels sometimes they're not that important. But this was a case in your example where it was important because the management strategy did need to change. And I suppose on that front, was this patient able to keep running,
Yeah.
or did you have to modify? Because I know I don't know if you use it, but the long stride walking test,
Yes.
where you put them on an incline or you increase
Yeah.
their stride length, etc., to get that extension. Is that something you use, and is that
Yeah.
something you modified if they could keep
Yes.
running?
Yeah. So one thing was with most runners, except with bone stress, I tried to keep them running. So I stopped the speed work, and she was doing a lot of hills. So we made those changes here. And even with the normal day to day life, I asked them to walk with shorter strides. So that is something which I include so to avoid that. So the main thing with this is once you know the pathology, the management is fairly straightforward, is avoiding the axe, which is end range extension, and really not letting it settle down. Very rare cases, which is getting more common now, is in very irritable cases where you're having night pain and they're limping and it's affecting. I usually refer either 2 3 consultants I work with, so I'll refer them for a guided. This is a bit tricky one to do ultrasound guided, so it's usually done by CT because it's quite deep and close to the sciatic nerve. So in very rare cases when you can't really get anywhere, then sending them for an injection and then starting the rehab can be really useful. But I've not seen anyone in my practice where we need to send for surgery. So they tend to do really well as long as we don't let them keep on pushing them into end range extension. And this is a condition I tend to see more in people who have failed proximal hamstring tendon rehab. So another point I'll mention here is if you're rehabbing somebody with proximal hamstring tendon and they're not improving, the first thing I'm thinking is this could be ischio-femoral impingement as well. So then I'll push them for an imaging. So this can mimic both hip impingement, bone stress. It's a great mimicker, really, ischio-femoral impingement. It behaves like bone stress, FA syndrome, and also like proximal hamstring. So it's a tough one to really catch it.
How hard is our job, right?
Yeah. Yes.
The last one I'll take you to, Benoy, which you mentioned with the bone stress injury, and you mentioned why it's so important that bone stress injury is picked up, is AVN. Um, AVN is something that I've spoken about recently. If anyone wants to learn about it in much more detail, I recorded a podcast with E3 Rehab so I've created a new mnemonic, which I titled Stairs P, which is just a tool to help you screen for AVN. But I talk all about it in that podcast, and we do have a post on Instagram on it as well. But for the sake of our discussion today, Benoy, what are some of the key things that you're looking for in your subjective to turn on that radar for AVN of the hip?
Yeah. So a key red flag for me in hip and groin is a thing not to miss is avascular necrosis. So especially when I work in my advanced practice role in Guy's Hospital, that's the thing I can't not miss. That's more my biggest concern. There are two things I don't want to miss is your bone stress and avascular necrosis, and this can be quite tricky because we know from the literature it's linked with some specific risk factors. So we know like one of the biggest one I see is people with long-term use of steroids or people who had long-term steroids previously. So people who come with rheumatological background who have taken a lot of prednisone, a lot of oral steroids, and then after 5 years they come with worsening hip pain. That's pretty much a big one. The other one where I see where it's linked to the people with radiotherapy, where they had cancer treatment extensively, which we see. And also we know it's linked with specific risk factors like alcohol. So people who are having excessive alcoholism and people coming from black population like sickle cell trait. And another one, big one is trauma. So if you had a missed femoral neck stress fracture, they can unfortunately convert into an AVN. And for me, if I have a young patient in the 30s who have significant hip pain and they're having like limping, night pain, that's one thing I don't want to miss is the question is this could be AVN? So this is where I would say skip obviously if you want to do the X-ray, that's fine. But again, same like bone stress, I would refer for urgent imaging and early orthopedic involvement for this condition. And the idiopathic one, the ones I see can be missed is the young ones, usually young males in the 30s who come with that. Because sometimes, there's a big the one thing which is really relevant here is I don't know about Australia, but a lot of men in the UK take drugs for bodybuilding and for aesthetic purposes. So that's something I routinely ask here is, are you currently on a cycle? Have you taken steroids for bodybuilding? And you'll be surprised how many guys. I think maybe 4 or 5 years ago, men used to be a little bit more cohort, bit coy about it. But now I don't think it's a big deal anymore. So they're quite open about it, which is great for me to know that I think it's something like 1 million men at least report to have taking for bodybuilding. So that's a lot of men. So for me, I think for especially people who are into bodybuilding and going to the gym regularly, that's something I don't want to miss is taking for recreational use as well. So it's a huge topic and I'm sure we'll go through that in detail, but those are the key ones: the alcohol, the steroids, trauma, previous radiotherapy, and sickle cell, especially if they're coming from African background. So that needs immediate action, offloading them, and then urgent orthopedic referral.
Yeah, and the management will be different, isn't it? Depending on
Yes. Yeah.
one, if they have it, two, how far along the pathology is, isn't it?
Collapse. Yeah. So that sort
Yeah.
of things where we can go in. So I think that's definitely if you're working in a more specialist environment or they're coming with a lot of pain, that is so. When you have a very irritable hip, somebody who's in a lot of pain, night pain, limping, my sort of the two things which come straight to my brain is it bone stress, is it avascular necrosis? Those two things generally tend to, especially in the early stages, they can be extremely painful. And that's one of the reasons where the imaging is extremely useful because clinically everything you do hurts. So there's no way you can differentiate between an acute bone stress and an early stage avascular necrosis because the tests are positive for everything. So the clinical test for intra-articular hip, as we know, is not specific in any capacity. It just tells you it's from the hip. So that's why that profile, careful attention to their sort of nature and what they did before will help us to separate from not missing out this sort of red flags.
Well done, Benoy. Not out of
Thanks.
breath, hopefully. I think should we try and summarize it? Because obviously we've
Yes.
spoken about a lot of things there. So I made some notes on how we can best put this down into a simple list for people. So the first one was a bone stress injury of the hip and pelvis, and you referenced the femoral neck. So that has severe consequences, and that is something that we absolutely cannot be missing as an FAI mimicker. So I'll use your example of if you've got an active male or female, if they've had a recent history of spiking their training loads, if you find they've got a low BMI, if they've got a history of red S, or you start to notice symptoms that related to red S, whether we're looking at menstrual cycles or dietary restrictions, and they've got acute groin pain, then your bone stress injury suspicion is quite high. For hip dysplasia, we've said there's no one test that's good here. A lot of the tests overlap with FAI and hip dysplasia, and they can all test positive. So the key is in the subjective. And you mentioned childhood issues, whether there is a family history of hypermobility or of hip dysplasia. Did they notice that their hips were clicking a lot as a child? Did they wear a brace? Were they a late walker? Was that one that you said, Benoy?
Yeah, yeah. Like developmental issues, they had developmental issues as well.
Yep. And you mentioned the Baton score uh, as well. And I think we're going to put up a new tool on the spot on our Spotify as well for people to look at. And then you mentioned hip OA, which can often hide in plain sight, particularly with athletic individuals. So if they've got a big sporting background, if they've had history of injury, they've got very stiff hips first thing in the morning, struggle to put on socks and shoes, getting in and out the car, we're thinking hip osteoarthritis. The proximal ITB pain, you mentioned the high C sign and the location of pain seems pretty important compared to the lower C sign that we see with FAI. And you mentioned a crossover gait pattern as well with walking or with running, and alongside hip abductor weakness as well. Ischio-femoral impingement, would you say extension is the key one? The
Yes, yeah.
extension movement is the key
And
provoker.
yeah, and the buttock pain, presence of gluteal pain. Yeah.
Yeah, buttock pain, and it can refer into the groin. We mentioned the long stride walk test, and we mentioned the ischio-femoral impingement test as well, which are two easy tests to do. You touched on MRI, talking about edema at the quadratus femoris if we're going to utilize imaging. And the last one was AVN, which is a massive red flag at the hip. So we were talking about steroids, rheumatology, you talk about alcohol, previous trauma, sickle cell disease, radiation was another one as well. So these are some of our key subjective signs when we're looking for an AVN. And if you suspect that, that needs to be referred on straight away for urgent imaging and possibly orthopedic intervention. There we go. Is that a decent summary, would you say, for nice
Brilliant.
people to take away?
Yeah, and the thing is, we have to remember here, which can be quite intimidating for people, is because we work in a specialist second opinion like you and me, we are more likely to see things like proximal ITB and ischio-femoral. The common things happen more commonly. So the more likely you're going to see is, in my opinion, is going to be either bone stress or early OA. That's more likely you're going to see on that. So it's important not to get overwhelmed, but having a checklist. So if things are not improving, having that access to a checklist so that you can go back and say, and the reality is, I don't really pick this up on day one. It might be on session 4 where I might have a suspicion. So as long as I don't miss a bone stress or an AVN in the early stages, I'm a bit chilled. I can take my time, see the response. So it's not like something is going to be massively. Let's say I miss a proximal ITB for 3 months. It's not a big, the rehab is still going to be useful. So I don't think we can be too harsh on ourselves on getting it right. Especially I had this conversation. I don't know whether you had a lot of junior physio feel like that bit of pressure. They have to get it right straight away. Like, oh, I have to,
Yes.
that on that. And I think that is not going to help you with the hip and groin. This is a slow growth where you need to have the discussion. So don't put more pressure than it's a hard area. So I've taken a little bit more casual approach. As long as you don't miss the big ones, I'm bet okay with that.
Yeah. I think you raised an important point there, Benoy. And if we do have any student physios or if we have some young early careers physiotherapists, osteopaths, chiros who are listening to this, yeah, don't put that pressure on yourself. No one knows everything, right,
Yeah,
Benoy?
definitely.
As
Yeah,
good as you might be, as experienced as you might be, we don't get things right first time. The common stuff's common, and that will just come with mileage. The more you see hip OA, the more you'll detect it, and etc. But I agree, don't put that pressure on yourself to feel that you have to nail it session one. Even
yes,
the best of the best of the best
yeah,
make mistakes sometimes, and that is
yeah,
okay.
yeah,
I think our key message here is what makes a good practitioner is that you are safe, first and foremost. You conduct a very thorough subjective assessment. Don't be too heavily reliant on your clinical tests. I think the key here is when is it appropriate to utilize clinical tests? And when it is appropriate, which ones am I going to utilize to help inform our working hypothesis from our subjective? Would you say that's
yeah,
how
definitely.
we'd frame it?
Yeah, definitely. I think the diagnosis in hip and groin is massively driven by your profile and history rather than clinical test. So that's the key message which you want to come across is the clinical test is really important for extraarticular. For example, if somebody with the GTPS palpation or adductor-related groin pain, but for intra-articular hip pain, it's pretty much the profile and the history is king. rather than the clinical test is more for the patient, in my opinion, is so they know that you're assessing well. For me, the history and the profile nails it. So if you get that, that's why we just go through this profile again and again here. So it's like a pattern recognition. So I would say like pretty much that's how I work, is pattern recognition. So they walk in, what they've done, and then once you hear this again and again, it's sort of become like second nature. And this is where I think podcasts like this and courses, which you don't really pick up in books or articles, is that the narrative, it's learning to that real world examples, which we're trying to bring here. So that's from me.
Absolutely. Thanks very much, mate. I couldn't have said that any better myself. On behalf of Benoy and I just want to thank everyone for tuning in to this podcast, because we know there's so much information out there, and we appreciate any time that you're able to devote to listening to us jabber on for 30, 40 minutes. So thanks for listening to this
Yeah, thank
episode,
you.
and we look forward to seeing you to the next one.
Take care.